primarily Waldeboro. There are not very many
That's
places to
Newcastle.
get education credits for medics here, so usually 4 or 5 services send people. Now they're just all watching online.
They were wooden.
I don't have any forms for CEs around for a while.
That's okay. I think
Still working for the
somebody
Air
we have here that
The guy came out, he said, this is a big deal.
What's that? So far, no.
We'll have to wrap everything up individually. So it's going to cost me too much, that's all I care about. I said, no, it's part of that. I came out, there were 2 guys, 2 trucks, and 1 guy said, well, we ran out of Tyvek suits. I don't know. So they just took the doors down, no gloves, no bags, no Tyvek suits. They did wrap this stuff.
Where's Home Creek here?
Turner.
Okay. So like a 2-hour drive or?
Oh, no.
Okay.
I went through Wayne, Reedfield, Winthrop, Augusta, and then out through Whitefield, Jefferson. I don't think I'm gonna go back. I'm gonna go back through Bath and then go up to the top, so I'm gonna head across through Dunn.
Yeah.
It's about the same, but it'll be a different.
It'll be a different drive.
I hadn't been through Whitefield. I used to 20 years ago when I got out of paramedic school. I worked at Delta and Augusta.
I've been, I already quoted
I
myself.
remember that for like 17 years.
Yeah, right.
Whitefield, Jefferson.
I built my shed, sure, I did that. I got a metal roof.
And I don't think I drained through that.
Yeah, must have changed.
No.
Yeah, O'Shea, what's the other guy?
Joni, there's a guy named Joni. Jay and I put a little crew in there for the roof.
You've been inside the building?
Well, I've been there because the guy fell through the floor of the new construction house. And,
What's the YouTube channel?
Waldeboro EMS has its own YouTube channel. I'm not sure what people are seeing, because I'm seeing something we did. I can't get this thing in the basement, so there's a mute button right here, but last time I pushed F1 and I reset.
I don't think that's gonna disturb it as long as you can verify that it's actually streaming.
She's saying she's hearing a lot of echoing on this.
I gotta shut horse and buggies out front.
Yeah.
Walk around, tiptoe with a horse window,
Now they parked it next to the Jefferson Green and tied up.
Yeah, the push button doesn't work.
The kids, the neighborhood kids just love sitting on the buggy.
I took a bunch of, pick up a whole kit there and all the stuff I needed, and I gave the tips how to do it. I got that roof on the shed.
Darren came over with a.
Fellow came in, 30 grade, temporary transvenous pacemaker, and called Lifeline.
Piece of hardware, this is.
We'll come out and pick them up, but
Have you seen those around Central Maine or paper making, like, where they get that from?
if it wasn't captured all the time, it was just barely, especially the right ventricle, and sometimes it would just lift up and you lose capture, so I guess they adjusted. So they actually came over without a medic and picked me up with the
Videos
flew
on
me
their
to Maine
website.
Med, which was great, because it's beautiful.
That's back to a company in Amherst, Pennsylvania.
That all worked out really well. The guy did fine. We had, I think,
Good luck.
7 miles.
it was out of miles, and I don't think the nursing supervisor even knew what I was talking about when I said, just
Worked
give
out
me
great. I
the
got my
little
block, so.
transvenous space that
the way
they found
stove
it,
just-
like
I did this
some
last winter.
back closet, and I don't think it's
Dust
been
off.
used. Yeah, it was an old, but it still worked. It changed the battery and it worked. And they flew me back to Eastern Maine, I think, that was just the protocol, they couldn't drop me back off the miles. And then I waited till the end of the shift, and one of the flight nurses drove me through Whitfield all the way back to Miles. It was great, because I got the rest of the shift off.
Maybe we've been live for 23 minutes.
Yeah, there's a lot of improvisation. at times
Probably.
when You need to get something done.
Yeah.
You just gotta do what you gotta do. I ended up in some really weird, in the back of pickup trucks a lot.
Yeah. Oh, yeah.
I got left when I was on orientation, I was in Brooklyn.
Yeah, I know where it is.
And, Steve Babin was a big guy, and Carl, big guy, and me, and the patient, had these, orientation, so I look on there.
Good looking jacket.
Yeah, Rich, this is Jeremy and
Jeremy,
pleasure.
Former lifeguard.
I guess what I say in here. I don't know how many's gonna be online. Mike's gonna.
There's 11 people right now.
11 right now. So we'll get that.
Sorry.
We'll get the license numbers and stuff if you can take care of that.
Yep, I'll just make sure, Dr. Lee, before you leave, you sign the
Yeah,
roster.
got it.
So I got nothing. So we'll just get started. Does anybody get anything? Before we start?
Yes, October 24th, a Saturday in Bristol, the New Harbor Station, with an all-day long program on CEHs. BLS skills, airway skills, trauma, medical assessment, so more will be coming out on that, but just October 24th at 8 o'clock in the morning and I'm there until about 4 in the afternoon.
Saturday.
On Saturday, yeah. I don't know about the price tag for non-Bristol people, I'll find out and get that published, but.
I'll put it on. I'll put it on the site.
Yeah.
Send it out.
She's invited Jefferson, Raymond, Waldeboro, Dr. Jerry today, and everybody, a little network is invited, CLC folks and all that.
So we got, okay, good. Anybody else? So we got two things here today. Dr. Lee's invited, is it Jeremy?
Yeah.
From, what's the official name, Maine?
New England Donor Services.
New England Donor
Yeah.
Services. And then Dr. Lee's gonna be doing some case reviews with us.
Yeah.
So. Oh, it's just Terry. So we'll get started.
Okay.
Thanks.
And do you want him stand at the podium, Mike? For
He can
the,
go wherever he wants to, I'm gonna.
can you pick it up all right for the TV there?
Yep.
My name's Jeremy Nato. My title now is Donation Coordinator for New England Donor Services. My background is started as a paramedic in 2002. Worked in a variety of places. Went to nursing school and did a little bit of traveling and worked at Life Flight of Maine out of Lewiston from 2009 till 2019, where I started this position. Essentially, my job title as donation coordinator requires me to go on site to whatever hospital a potential organ donor is located at, and it's typically, well, it's always in an intensive care unit. And my job is to help facilitate the medical care once a patient is declared brain dead, or to help facilitate the processes that need to be in place for a patient to donate after cardiac death, and I'll explain the difference between the two of those. There will be someone, a donation coordinator on site 24/7 until that patient donor is brought to the operating room to have their surgery to recover the organs that people will receive. So a little bit about our organization. We're an OPO, which is a federally designated OPO, which means we're an organ procurement organization. There are dozens across the country, and they're all regionalized. So New England Donor Services used to be, you might have heard the phrase NEOB, or an NEOB case. It used to be New England Organ Bank. We're now New England Donor Services because we combined with two other programs down in Connecticut. We serve Vermont, Connecticut, New Hampshire, Mass, Maine, Rhode Island, and oddly enough, Bermuda is part of our OPO. Haven't been to Bermuda yet. Yeah, I don't think we've done a Bermuda case since I started, but 198 acute care hospitals, 14 transplant centers, and 34 transplant programs. So especially in New England, we're kind of the hub of organ transplant. The first successful kidney transplant was done at what is now Brigham and Women's in Boston. So kind of the birthplace of transplantation in the United States. We're a nonprofit agency. We have designated service areas, which I just described. We coordinate the recovery, preservation, and transportation of organs donated for transplantation. We first determine medical suitability, and then we will approach the family and essentially ask them if they think that this would be appropriate for them and for their loved one, if their loved one had not gotten the heart on their license and registered to be an organ donor. And we also do a lot of outreach with the public, which is what I'm doing currently. Organs that can be transplanted: heart, lungs, liver, kidney, pancreas, and intestines. Those are what I predominantly am involved with. Tissue recovery, organs are considered life-saving measures. Tissues are considered life-enhancing. So they certainly can, have someone that needs massive, skin grafts or bone grafts or things of that nature. It's not technically life-saving, but it's quite life-altering. With corneal transplants, literally giving vision back to somebody. Heart valves, pericardium, blood vessels, and nerves. The difference between organ and tissue recovery is organs need to be taken immediately. So we will start the surgery when the patient's heart is still beating and the organs are being perfused. Tissues can be recovered within 24 hours following asystole.
What is the pericardium used for?
So it's used for, I think they take the blood vessels out of the pericardium, and they also use it for cardiac grafting. They'll make biologic patches, and probably other stuff that I'm not even aware of. I'm not delved far into the tissue world because it's a completely, really separate entity. But my son was born with tetralogy of Fallot and had a repair at 4 months old, and I didn't even realize this before I worked in the organ bank. But the importance of tissue donation as well as organ, he has a patch on his pulmonary artery from the repair. So we collaborate very closely with hospitals. We have a long board. We call it the board. But if I open up my phone, there's probably 30 referrals on the board right now. Hospitals all over New England with very sad cases of people that could potentially become an organ donor. We work very closely with the staff. We make phone calls in the morning and evening to track their progress and see how they're doing. If they are getting better, great. If they're starting to get worse, or if they're talking about doing brain death testing or talking about comfort measures and removing the tube, is that at that point we would speak with the family.
If somebody dies from COVID, are they a potential donor?
No. Right now, no. I was just talking with Dr. Lee about this. When this started, when COVID hit, we didn't know what to do. We were still getting these referrals, but it was pretty interesting as people, and there's two schools of thought as to why this happened. We're not even really sure, but the overall referrals, just people should still be getting sick, having heart attacks, strokes, motor vehicle accidents, all the, COVID shouldn't have augmented that much, but it did. The referrals went to the point where we were getting maybe 2 in all of New England a day, when it's usually 200. So the thought is that a lot of people were dying at home. People were having chest pain, stroke symptoms, and they didn't want to go to the hospital. And certainly you saw when you're driving to work, you might see a car and not 55 of them on Route 1. So it's pretty interesting. So how this will apply for you folks, it's something just to keep in the back of your mind. You may have an unfortunate circumstance where, a patient is in a motor vehicle accident, their pupils are fixed and dilated, they don't have a cough or a gag, but their heart's still beating. I didn't really realize what we were doing at times in terms of flying someone from point A to point B to a trauma center, but the point of that can be, this 24-year-old individual has the potential to save 7-8 people. So there is some implication for what you folks do. Clinical clues for hospitals to refer to us: any patient that's on a ventilator who has a non-recoverable injury or condition. If any patient's in the hypothermia protocol, which for those of you who don't know what that is, cardiac arrest patients used to be cooled to 32 degrees for 24 hours and then rewarmed, because there was the thought is that the metabolic demand of the brain is reduced, so you can preserve brain function following a cardiac arrest. We don't get them as cold anymore. It's basically just 34 to 36 degrees, just not hyperthermic. So any patient that is in that protocol gets called into us prior to discussion of DNR. Even if Nana is 178 years old, we still encourage people to call. Any de-escalation of care, comfort measures, during that discussion, they should be calling us. And if a patient is going to undergo brain death testing, every hospital has their own process, and it's specific and it's linear, and it's formalized to determine brain death. It encompasses a clinical exam testing your neurologic reflexes, your cranial nerves, and they're disconnected from the ventilator for 10 minutes to see if they initiate a breath. And at that point, they will be declared deceased, even though their heart is still beating. The donor registry, which you guys are probably all familiar with, in the United States, it's an opt-in program where when you go get your driver's license, you are asked if you want to be an organ donor, and you say yes or you say no. You can also, if you don't have a driver's license, you can go on the donor registry and sign up to be an organ donor. There are countries, I believe Australia is one of them, it's an opt-out program. Every citizen is an organ donor unless they specifically say they don't want to be. So once we identify a patient that's a potential organ donor, we'll kind of follow in the background. Part of my job is, working with staff, speaking with them on a nightly basis to see what the plans for the day are, how is the patient progressing, for better or for worse. We'll also suggest certain tests, like if we're trying to evaluate in the background if a patient could be a kidney donor. They're not our patients, they're the patient of the hospital at this point. So we'll ask, do you mind getting a UA? Or, we wouldn't ask them to send them a CAT scan, but we'll ask for simple blood tests. Can you draw a liver panel to see if their liver is possibly transplantable? Our FSCs, family service coordinators, they are the family liaison. If we have to approach a family to ask them if they felt that organ donation would work for their family, these are the folks that we have talk to the family if we can. They're all clinical social workers, crisis counselors. They all are they all have heavy social work backgrounds. They also support the family through the entire donation process. This is my job. Work primarily with the ICU team to optimize function of all organs. So essentially, if a patient is declared brain dead, they're no longer under the care of the hospital. They're transitioned to us. I work with the nursing staff to essentially maintain end organ function, obtain all the necessary tests that we need. If a patient is going to be a potential lung donor, we need a CT of the chest, bronchoscopy to look at their lung anatomy. Cardiac potential heart donors get a cardiac cath. If it's medically necessary, they all get cardiac echoes. We also draw serologies and HLA. Serologies are pretty comprehensive infectious disease panel to include HIV, HCV, syphilis, things that I'd never heard of, like strongyloides and Chagas disease, and depending on their travel history. We also support the family, obviously, once the social workers are 8 to 4, 9 to 5 type folks typically. We're there overnight in the hospital. So we do have a lot of communication with the family.
How large is that in personnel?
My organization? Oh, geez. So I don't know how much support staff we have in the offices, but I mean, there are people that I probably will never even meet. For donation coordinators, there are 4 of us on the main team. We rotate 24-hour shifts, and we cover basically every day. So there's 4 in Maine, there's 6 in Boston, 5 in New Hampshire, probably like 25 in New England that do my job, 25 to 30.
But you had multiple patients at once that were doing this, you had people each
Yeah, it's not overly uncommon that we'll have, I'll be on a case at Maine Med, and there'll be another case going on. So a donation coordinator from either Boston or New Hampshire team or whoever's available, which is why I'll end up I've been in Leahy in the last month. I've been to Leahy, Boston Medical Center, Dartmouth, Catholic in Manchester. So you get to see a tour of New England, a really sad tour of New England.
And who pays for the testing once the patient becomes?
We do.
Okay.
Yeah. So after the patient is declared, all the testing that expense is incurred by us. The hospital will bill our organization. It's across nations in the entire world. The World Health Organization outlawed the sale of organs for obvious reasons. How that differs with my organization and every other OPO is it needs to be financially funded to work. So we are reimbursed by insurance and by the transplant centers themselves will pay for our services to bring the organs to the patient that needs a heart, and that patient's insurance will cover that operation. If you want to really go down a rabbit hole, look up what they've been doing in China with the prisoners. My medical director actually went to my medical director got kicked out of China 2 years ago by the Ministry of Health, and he went to the Pope and spoke to the Pope. His name's Dr. Delmonico, and they've been doing a for-profit, basically travel tourism for organs. So if you're a Saudi Arabian prince and you need a kidney, they drew your blood, you went to China, and the next day there was a match. And they found that they were finding these matches in the prison system with expedited sentencing and trials. So,
One way to do it.
it's pretty crazy.
Years.
So once I get all my testing done, I draw blood for tissue typing, so that's sent to a lab at the Brigham tissue typing lab, and they will, anyone that's on the transplant list has given their blood to this lab so they can do cross-matching if it's for heart or lungs. For kidney transplantation, you basically have 6 antigens on your kidneys, and anyone in need of a kidney has given their blood to a tissue typing lab. They know what antigens they have. So that's how the match works on kidneys. For heart, it's an actual cross match. They'll take my donor's blood, the potential recipient's blood, mix it around in a dish, and see if there's any sort of hemolytic reaction. I try to place heart, lung, and liver. Kidneys are actually done by our operations center. Medicare and CMS guidelines, they oversee all kidney transplants in the country. That's why hospitals have to work with us if they want to continue to get CMS funding and Medicare funding. It's cheaper and more cost effective, I should say, not cheaper, to transplant somebody with a new kidney than it is to continue on dialysis. So the government took a big interest in that. Once I have my donor is managed, they're hemodynamically stable, ideally, then I'll run my lists. So the lists are run on a computer database through DonorNet. Every possible recipient in the country is listed, and it's based on their medical acuity, how long they've been on the transplant list, geographically where they are, and physically what size they are and their blood type. So that Mickey Mantle can't get 5 livers anymore. The President of the United States can't get if the President needed a liver, he would go into the same organ sharing network as you or I would. So it's completely randomized based on clinical data and not based on socioeconomic status or anything like that.
Unless they go to China.
What's that?
Unless they go to China.
Unless you go in China. Yeah. UNOS is the United Network of Organ Sharing. They oversee tissue typing, ABO. They run DonorNet. They designed this system, and that's what we've decided nationally works best for placing these organs. The heart. So what happens in the operating room, the patient is essentially opened up, their heart is still beating, they're being ventilated by anesthesia, they've been declared deceased, and they are deceased. If the our transplant surgeons will cannulate the aorta, and they'll cannulate the femoral artery, and essentially when it's time to cross clamp, all these lines are already in place with big bags of fluid and big pots of ice. Cross clamp occurs at the aorta. The blood is basically flushed out of the body, replaced with a preservative, ice cold preservative solution, and at that point the clock starts ticking for all of these organs. The heart, from the time of cross clamp to the time of transplantation, it's considered ischemic time, warm ischemic time, is 4 hours. So there's a lot of coordination in the OR between myself, the recovering surgeons that I'm with, and the implantation surgeons, wherever they may be. They have to have that patient who's receiving this heart already opened, prepped to receive this heart. So it's kind of heart's challenging. Next are lungs, pretty similar situation.
So that's 4 hours from the cross clamp time to the time that they unclamp the ex-patient to the heart center.
Yeah.
Wow.
We have pumps now. Kidneys and liver have been going on pumps for a while. They're perfusion pumps. They look like a briefcase. Lungs, liver was next. Livers are able to be pumped. Mass General is doing a trial on them right now, mostly just to improve function. What will change greatly is when heart and lungs can routinely be placed on pumps. That's going to expand where these hearts can go. So I imagine when that becomes proven medically to be beneficial and not detrimental, that I think that our allocation process will change. Intestines and pancreas are very rarely recovered. The pancreas is such a gentle organ that you can't touch it. You have to touch the surrounding tissues only. If you touch pancreas, it literally falls apart. With diabetes control now, you don't see a lot of pancreatic transplants. Usually the pancreas is, along with 2 kidneys and they'll call it a multivisceral transplant with a whole stomach contents for a child. Same with intestines. Intestines are rarely recovered unless it's for research, where you'll see the need for an intestine will be a child, someone born with whatever gut malformation they may have had since birth. Kidneys are probably our most recovered organ, and they can go up to 24 hours. So, if you're allocating a liver or a heart, the first center that pops up is usually like Boston or, maybe Pennsylvania or New York, because of the geographic implications of what the organ can, how long the organ can be out of a body. Kidneys, I looked at a kidney list the other day, and the first recipient that was perfect antigenetic match was actually in California. So we will try to allocate kidneys in the United States, and occasionally they'll end up in Canada. So.
Do you know roughly what the size of the transplant list is for kidneys and hearts?
It's massive. I wish I had that number.
Thousands.
Thousands, yeah. Just my liver list the other day, it was a patient that was hepatitis B NAT positive, antibody positive, and HCV core antibody positive. That list was still 290 people long. So, when I have my organs placed, I'll call the operating room and try to schedule an OR, and then it's the myself and a surgical recovery technician will work to facilitate the transportation, making sure that the surgeons know what airport they have to go to, the travel time. We used to rely heavily on, actually, I've called the ambulance before to get a surgeon back to the plane with the liver. Now we have a company out of Portsmouth, New Hampshire that specializes, all they do is drive around organs and personnel and blood tubes. So that's gotten a lot easier. The logistical part can be really challenging between working with an OR that says they want this done at this time. Then you have a liver transplant surgeon who says, well, I want to go at 3 a.m, because if we take a liver out at 3 a.m, he can still have breakfast and coffee and show up to hospital late. One of those little things you start to realize as you're working. But making everybody happy, just like what you guys do, is always challenging. This is a letter that Mary, a donor's mom, wrote. My family and I hope this letter finds you well. We've been praying for your health and well-being for over a year now. Thank you so much for taking the time to read the words on this page. Last year in October, we lost our wonderful, kind, loving, and talented son in a tragic accident. Troy was a happy college student athlete who loved life so much that he knew the importance of giving it. When he was just 16, he made the decision to become an organ donor. Because of that decision, it was easy for us as parents to honor his wishes when he died. It was devastating to lose Troy, but we gained a tremendous amount of comfort knowing that others are living on or are better off because of his gifts. We are so proud of him. When our son died, 7 miracles happened. They were not the miracles we'd originally been praying for, but they're miracles nonetheless. Our son's organs have been passed on to you, and that has brought us much solace. So, it's not uncommon to see at all. Initially, it's a really hard decision to make, especially, if your loved one hadn't designated themselves as an organ donor. But over time, people, it is a good thing for healing for most people. After we've interviewed them a year later or what have you. Tissue donation, like I said, is done after asystole. You have 24 hours to call in this potential tissue donor. If you folks work an arrest, and I'm not sure what the protocol is now, they stay in the field?
Yes.
And funeral home comes? So there may be implications for you to consider, or at least bring up, who might call our organization, the organ bank. Certainly not an unattended death, but someone that had a heartbeat, a confirmed heartbeat at a certain time, maybe something you want to think about.
Do funeral homes directly call you?
Not always.
Okay.
Not always. Like I said, the tissue side is something we really just don't get that much involved in. The woman that did this presentation is better versed in the tissue side, but certainly it's something to consider. And I don't think we do have a lot of outreach at funeral homes. They're so scattered in Maine, it's really challenging. There's so many of them. Any patient who expires in the hospital is a potential tissue donor, and referrals may also come from hospice, EMS providers, medical examiners, and nursing homes. So, any patient who's been pronounced in the scene terminated resuscitation can be called in. This is some of the referral information that you'll be asked.
Is it more common to have families give permission for tissue or organs, or is it about the same?
It's about the same. Just anecdotally from my experience, people tend to want to donate organs more. The tissue recovery is not always done on site. Sometimes they have to be moved to a different place, like for instance in Westbrook. If you're in Massachusetts or New Hampshire, they're typically taken to our office in Waltham for the recovery and then returned back. There's a law from the early 1800s in Maine that I'm sure they didn't realize the implications that this law would have, but if you take a deceased body over state lines, Maine will let you leave with it, you just can't bring it back. So
how do you get around that?
We don't. We have to do our tissue recovery in Maine. So we have a site in, I believe, Westbrook. But we'll try, if the patient was an organ donor, we'll try to do the tissue recovery right there in the operating room. One thing that you folks should, when you do call this in, that you may get asked about the medical examiner. We call the medical examiner on almost every case because as of late, unfortunately, a lot of our cases are overdoses, suicides. We'll still call even if someone suffers a known CVA or whatever event that is confirmed. We'll still check to get donation permission. They will look on the registry, so you can pull it up online and check your own registry status to see if you show up. You may think you're an organ donor and you're not. You may think that you're not and you are. I'm not here to tell you you should or you shouldn't. One thing that I've seen from my experience of doing this job in this short period of time is that having your wishes laid out for your family beforehand is huge. I've seen families really struggle with this decision. Because someone didn't put themselves on the donor registry, does that mean that they wouldn't want to do this? No, not necessarily. Patients have, I've had families say, well, he did at one point, but he's changed his mind. I've heard him change his mind. Unfortunately, the registry is it's a legal document. And from our standpoint, we have to try to honor the wishes of this deceased individual. So as long as I'm 42 years old, knock on wood, I hope I got some time left, but I've made my wishes known to my family, and it should be pretty clear for them if something should happen to me.
So the letter that you read was by a 16-year-old who chose probably when he went to get his driver's license and registered.
Yeah.
So if a minor says, I want to donate my organs, his family says, no, you can't, who has precedence?
Our lawyer. That happens. I'm serious. That's something that we go right up the chain. I don't know what kind of legal precedence there is. Knock on wood, I haven't had that experience yet. I do know that I think in that particular situation where a patient is a minor, we would probably walk away.
Yeah.
I can't say for sure.
That actually happened to me. So
it did.
I went to do my driver's license when I was in high school. Tried to sign up, my mom was there, and she said, there's no friggin' way you're going to do this because I want your body whole when you die, if you die. And she said, you can do it when you become an adult. So on my 18th birthday, I did it without telling her. But who knows what would have happened.
You're getting away with it so far, so that's good.
But I always wondered after that.
It can be super challenging. Families and I see their point too, if you have a son or daughter that dies, and even if they're in their 20s, what we do takes some time. It takes 48, 72 hours to pull this off, and that's really, really tough on people. Oftentimes they've been there for a week or two, going through the worst time of their entire life, and then you walk in, I come in and say, I'm really sorry, but he was a registered organ donor too, so it can be a challenging situation for sure. These are just some things to look at. If you're going to be calling this in, I'm sure you guys see your share of overdoses and what have you. So be cognizant of it. If the patient's got a needle in their arm, make sure you mention it.
Do you have any age restrictions? Does that come to a point where you just say it's not worth it?
So, it's technically 90. So 90 years old, 89 years old. An 89-year-old who is declared brain dead can still donate their liver. There's two types of donation scenarios. One was the brain death scenario, which I told you about. Well, 10 years ago, they started finding that they could get organs after a natural death if it happens in a certain way. So how that typically works is a catastrophic brain injury, a bad stroke, but the patient isn't all the way brain dead. They might still have a weak cough on suctioning, or they may have a pupil that's still, are they technically alive? Yes. Do they have enough brain function to ever recover? No. And if the family elects for comfort measures, like you normally would, say this is not what he or she would want, we will offer them donation if the patient is medically suitable to do that. And how that works is I would set up the OR in the background. We would draw some of the blood. We can't do all the testing that we normally would because the patient is not our patient. It's still the patient in the hospital. And I would set up the OR, have our surgeons ready for whatever organs we were going to recover, have already placed these organs, and then the patient would be extubated in the room with the family and the comfort measures, however the hospital normally does that, whatever medications they give, and we're just in the background. And if the patient passes away in less than 20 minutes, they can donate their liver, and it's up to 2 hours in some facilities where they could still donate their kidneys. But that is the reason that's more challenging is that's warm ischemic time. So as your body's dying, the longer it takes, the longer you're in this hypoxemic, hypovolemic state where your blood pressure is 30, your heart rate is 40, and your SAT is 50. That's bad for your organs, and so the outcomes are not as good. But
So you will take a 90-year-old liver and give it to somebody else?
Yeah, 89.
89.
So you're still good, Richard?
Yeah, more years.
So I can still give mine then. Another year.
You, that would be, for the DCD scenario, you have to be under the age of 65. If for you to be an organ donor over the age of 65, you need to have been declared brain dead. So this is more medical examiner and tissue recovery stuff. This is all absolutely pretty boring.
Let me just emphasize what you just said, because I think that was important. So what you meant, I think, was if you're 65 or over and you're in a cardiac arrest situation where you're pronounced dead at the scene, you're not eligible to donate.
You're not, if you were pronounced dead at the scene, you're not eligible to donate your organs at all.
Okay.
You're eligible to donate your tissues. So the scenario that I described for donation after your heart stops, there was 24 hours of work prior to that. So we'll ask the family, we understand that you want to withdraw our support. If do you think this is something that they would want, or especially if they were a registered donor, we'll say, this is something that they wanted. Are you okay with doing this?
Okay,
You're
so
right.
I think what you were talking about, the distinction was somebody who's still on life support but declared brain dead at 65 or over can still donate organs.
That's correct.
But somebody who's extubated, comfort measures, and
Has to be under 65.
has to be under 65
Yeah.
to donate organs.
Yeah, sorry, I don't know if I wasn't clear about that. Yes, that's exactly right. Some signs that were absolute rule outs for tissue. The reason, so we can do, we will allocate and place organs from people that have HIV, from people that have Hep C, and from people that have Hep B. Tissue does not, you will not be eligible for tissue because it's considered life enhancing. So we weigh, as a medical culture, we've decided, weighed the risks of not getting your liver versus not getting your bone graft. Bone grafts are going to be 7 or 8 different people mixed. So it's impossible to track infectious disease. So if there's any sort of high risk behavior that we do a lengthy risk assessment interview with the closest family member that we could find. If there's any risky behavior with this individual, they won't be a tissue donor. And obviously if there's any evidence of IV drug use or known hepatitis or HIV.
Is that hepatitis B and C only?
Both.
Both?
Yep.
What
So
about hepatitis A?
Hepatitis A, no. So hepatitis A is different. That's like an acute infection. Someone that has had it historically, that's not that big of a deal.
Okay.
Hepatitis C is 98 point something, but depending on the genotype of the Hep C, it's up to 98% curable. So they will take, if I have Hep C and I'm donating to Dr. Lee, they will, he's been on the transplant list. Let's say, look, Dr. Lee, would you be willing to take an HCV liver if it came available? Most people say yes. And the ones that say no, as they work their way up the list, they decide to say yes because, you get sicker on the list. And with Harvoni, the drug that treats HCV, and our ability to transplant those livers happened almost concurrently with this opioid epidemic. And we kind of forgot about it because we've got another problem now, right? But it really hasn't changed. The opioid problem is huge. And every year we're transplanting more and more organs. I would say half of my donors. I did see a strong reduction in it post-COVID, but prior to, I'd say at least a third of my donors were from overdoses. So Hep B is not as much of an issue because most people have been vaccinated for it. Donation is an extension of good end-of-life care and helps families with their grief and loss. That's an opinion, but I do agree with it. I think over time, people, unless it's a strong religious belief, I think that families do find some comfort in the fact that something good happened. We're basically a bridge between donor families and recipient families. So if your child donated an organ to somebody, we'll tell you the age of that person and the sex of that person and what organ they got. So for instance, your son's liver went to a male in his 30s. We do allow for families to meet, but it has to be both-sided. So we'll act as a conduit. It typically doesn't happen very fast. Sometimes it's a year, sometimes even 2 years. People come to terms with certain things, will decide that they want to meet this person. Sometimes the recipient wants to meet the family of the donor. They'll contact us, we'll contact, if it's the donor that contacted us, donor family, we'll contact the recipient family and say, would you like to meet? And when it does happen, it's pretty incredible. I've been to some conferences where, like, this gentleman was with the young family of the son who overdosed and gave him his heart. I mean, it's really crazy emotional stuff. And they become, in essence, a family together. Skin grafts, for cleft palate, post mammograms, burns, that's where your skin donation will go to. Bone and tendons for arthroscopic surgery, replace MCL tears, back surgery. Corneas can restore your sight. Vascular tissue essentially restores health. So heart valves are big, especially in kids. To the world, you may be one person, but to one person, you may be the world. I like that quote. And that's it. Sorry, that was long.
No, that was great. Thank you.
Ask away.
Are there any diseases that rule up other than the Hep C?
Cancer. Cancer is the biggest one. Cancer is the scariest one for us.
Yeah. Is it all types of cancer?
Some are worse than others. We'll move forward on certain people that have had certain types of cancer historically. There are some that are much more insidious. Any history of breast cancer or skin cancer, we tend to stay away from. Those types of cancers can pop back up, 6-7 years later, and that can be a big problem, obviously, especially if even if it's to one donor. But there have been cases where upwards, I think it was 7 people got cancer from one donor, so it's a big deal. Part of my physical assessment is going over these folks with a fine-tooth comb and seeing if there's any suspicious moles, which I don't know about you guys, but I didn't know anything about moles before, So I'm taking a lot of pictures and uploading them into our system, so our medical directors, and we get a lot of dermatology consults on site. The joke is you always find these moles at 2 a.m, so don't do your physical assessment at 2 because you're not getting a derm consult at 4 a.m.
How much progress has there been on transplant rejection and longevity? Do you even know?
I can't speak overly intelligently to that. One thing I do know is that it's kind of an organ system, like lungs and liver, or for whatever. Lungs are very challenging for if you get a double lung transplant, your life expectancy is not long. Liver is also very challenging. It's kidneys and heart do very, very well. In terms of anti-rejection medication, I don't know if there's, I'd have to research it. I don't know. So
anecdotally, that makes sense. It seemed like when I was first in my career, we'd have a lot of visits from kidney transplants or even heart transplants with rejection, and now it's very, very common. The
liver's challenging. Not so much that they don't necessarily get rejected a lot, they just fail a lot. Lungs especially too. And you can trigger an inflammatory response in the lungs because that's where you get your infections mostly, and you're immunocompromised with your anti-rejection medications, and then you get a rhinovirus or whatever, and that can trigger an inflammatory response, and now all of a sudden you are rejecting. Is it true rejection? Sometimes I don't know, but it's a problem.
how much of the liver is actually transplanted?
The whole thing. Yeah, the whole liver. Any donor under the age of 40, we will ask whoever's accepting that liver if they're willing to split it. So the left lobe of the liver is a lot smaller. Is it the left lobe? Yeah. And it's not uncommon to split that liver, give the large lobe to an adult and the small lobe to a child. So especially a young, healthy donor with no risky behavior will always ask if they're willing, if the recipient is willing to share their liver. And believe it or not, most of them say yes because, they're so fortunate to have that gift, so.
I have one final question.
Yeah.
If someone wants to donate something as a living donor, does your organization get involved in that at all? So it's directly through the...
That would be like, so in Maine, if you want to, at Maine Med, Dr. Whiting does, you'd approach their center at Maine Med, their kidney surgery center, and say, I want to be a living donor, and they'll facilitate that. We do directed donation for kidneys, well, actually for every organ, but typically it's kidneys, where, a family might say, Jack down the street wants a kidney, we want him to have this kidney if he can. So, and that occasionally works. That is the one time where the list doesn't matter. If you happen to have a good antigenetic match for a kidney with someone that you want that kidney to go to, we will honor that.
Anybody else?
No, it was cool.
Thank you, Jared.
Thank you.
Appreciate
No, it was good being here. Appreciate it, guys. Thanks for having me. They called, the guy from work called me, I don't know, I think we started talking in the winter, didn't we? It was before the pandemic.
It was before the pandemic.
And you must have called the Waltham office directly, because he's like, is this for a bunch of EMS guys? And John called me and he's like, this is all you.
This whole thing's under my account.
I'm like, that's all right.
I'm just gonna put it in. Okay, that's fine. Okay.
It was good seeing you again.
Yeah, it was great seeing you, Jeremy. Thank you.
Guys. Thank you. Yeah, thanks for having me.
Thank you. Thank you again.
Yes, no worries.
So, is it my imagination, or does it seem like the call volume has gone up?
It's gone up.
Yeah.
Not where we
We're
were.
still, we're still 150 calls behind we were last year.
Yeah.
We're above last
Yeah,
year.
you're about-
Yeah, we did have quite a lull there for a couple months.
Yeah, I got the impression people just weren't calling 911. They were just getting sicker, and everybody that I talked to was sick, was afraid to go anywhere near a doctor or a hospital. It's interesting. So I could talk about anything, but I've got a few cases that I thought were really interesting. If you guys have any questions, even if it's just about general topics or COVID, let me know. I've got, I think, Mike sent me 4 cases. One of them I'm not going to do because I wasn't able to get any follow-up on that.
That's got a name on it, guys. Okay.
Yeah, here, I'll just, I can do this a little bit differently.
For some reason when it prints out, it's a long narrative.
Yeah, I think what I'm going to do is I'm just going to talk about these cases because the narrative really doesn't help you at all. It's just to remind me of what the cases are about. So the first case was earlier this summer. Derek's not here. He
He's listening.
Oh, he is. Good. Okay, so the reason I wanted to talk about this case is because it's a 22-year-old male up at the quarry here in Waldeboro who he said he fell down on a piece of glass, but he was in an altercation after a lot of drinking. And when Waldoboro got to the scene, he had an obvious wound on his back, an open wound, complaining of pain there, but he was also feeling short of breath. He had normal vital signs for most of the time. He got oxygen, IVs, and he was transported toward Miles. He had a pretty decent oxygen saturation on room air before all this started, but as he was being transported, he started getting worse. And by worse, symptomatically, that was first associated with some confusion. He had been completely oriented and alert and with it, even though he was intoxicated. But he started to become confused and talk about things that weren't real and maybe hallucinate. And about that time, his oxygen saturation started to diminish, and he started complaining of really feeling very short of breath. The idea that he had a penetrating wound in his back occurred to the paramedics, and there was some suggestion at the site of the wound that there was some air leakage or bubbling. And there had been, because at the scene that was a consideration, a three-way compressive bandage was put on, the kind that allows air to come out and not go into the wound to try to prevent development of a pneumothorax. But it became pretty obvious that this kid was getting worse, and one of the primary considerations was whether he was developing a large or a tension pneumothorax. And to remind you, a tension pneumothorax is the type of pneumothorax. A pneumothorax by itself is intrusion of air into the chest cavity, but outside the lung. So normally when you take a breath, your lung fills up with air. The lung surface is directly adjacent to the wall of the chest. There's a potential space there, but the two membranes are directly sliding against each other. In a pneumothorax, you put air into that air or some gas into that space, and the lung collapses, and that space fills up with air. If it gets large enough, the pressure of the gas not only collapses the lung, but also collapses the heart. And in those cases, you basically are looking at somebody who has cardiac arrest, and there's really nothing you can do with CPR and drugs because it's a mechanical problem. The heart's compressed and it can't expand because there's pressure around it, pushing it and keeping it from beating. So this fellow had signs of a tension pneumothorax. Does anybody remember clinically what those look like if you're just looking at a patient? Any tracheal deviation, JVD, and that's because you have pressure that's actually physically shoving the trachea and the bronchus to one side or the other. The JVD is because you're compressing the heart, and the venous return to the heart is impeded. So all the blood that's supposed to be going back to your heart gathers in your veins, the veins you can see. So everywhere you look, those veins get big, and the easiest place to look is right here. And he actually had both tracheal deviation and JVD. What about objective signs? Hypotension, because you're putting pressure on the heart, and hypoxia, which this guy had. Now, generally, in those cases, you don't really have a lot of time to do other testing. We say in the hospital that tension pneumothorax is a clinical diagnosis rather than an X-ray diagnosis. And I can think of about 5 cases that I've seen. Fortunately, all of other patients belong to other doctors where the diagnosis was made on a CT scan or a chest X-ray. As the patient was expiring and gasping, the doctors would say, or somebody would say, well, let's just get a chest X-ray. But if you've seen enough of these, you know that you really don't have a lot of time to work with this. You've got maybe a few minutes before the heart is completely collapsed and the person goes into arrest, and then you're really behind the gun. So Derek was struggling with whether or not to treat this because they were very close to the hospital entrance by that time at Miles. And and the patient was looking pretty bad at the time, but he decided, and I think this was the right decision, to do the procedure, which is to vent the lung space, or the air space between the chest and the lung, using one of the kits that you guys carry, which is a pre-calibrated kit for tension pneumothoraxes. And I think all of you are probably familiar with what's in that kit, but it's basically a big needle with a catheter. Is there a wire that goes through the catheter? Do you know?
It's basically a 14 gauge IV needle type, and then you just pull in the needle and leaving them.
And I think there's a syringe, or there's some kind of something you can put saline in on the end of the needle.
He used an empty flush.
Okay, so that's not part of the kit. Got it. So what he did, and there's a couple of different ways to do this, but he went the old-fashioned way, which is in the second intercostal space, which is generally, I think this was on the left side, which is just below the collarbone. And you just find the rib space. It's pretty easy to do because you can't put the needle through a rib. You just have to kind of get into the space. And when you do, the needle goes in very easily, the catheter alongside with it. And if you're doing it with some forethought, which is I think what Derek did, he put a syringe that had fluid in it, the flush. And as he put it in, he knew he was in the right space because the pressure of the gas went through the needle, through the catheter, and into the space, so you could see bubbles in the syringe. And that's a really, really nice way of confirming that you're in the right space. And then you pull the needle out, leave the catheter in, and if you do it right, usually, you know immediately because the tracheal deviation disappears, the JVD disappears, but more importantly, the patient usually takes a breath and looks at you and says, whoa, I feel so much better. And that's exactly what happened with this kid. I think Maine EMS now teaches people also, or maybe primarily, to go in the fourth or fifth intercostal space on the side, which is a very acceptable way to do it. In the left side, there is a small increased risk that if you use a long enough needle, especially the 14 gauges that I remember using, which were 2.5 inches, that you can penetrate the heart, because usually the heart is in that vicinity. So that's the reason why in initial ATLS teaching, we always taught to go up here, because if you do it on either side, it doesn't really matter. You're always away from the heart. So in this case, if it's the right lung, it doesn't matter. You can stick something in here easily without thinking about hitting something bad. But on this side, you always have to kind of worry if you're too close to the heart or not. So I think that's the reason that Derek chose to go through this space here. The patient did well. Actually, he went in, I think had an initial flat chest x-ray, which didn't show much, then went to CT scan, where it was confirmed that he actually had a small residual pneumothorax. In fact, it was so well drained, the pneumothorax was just barely visible. And one of the questions by the doctors later on that weren't involved in the case was, did this kid even have a pneumothorax? And I think that came up because he was discharged from the ED with instructions to come back in 24 or 48 hours and have a second x-ray just to make sure that he hadn't reaccumulated. And he did well based on a single needle with no need for a chest tube, and healthy kid who had what I really truly think was a classic tension pneumothorax. So that was a really interesting case that I thought was dealt with correctly. Derek told me that it was the first one that he'd ever done, and he knew he was going to get shit from somebody like me if he did it, because he knew we watched him, but I thought he did a really good job, and his judgment in determining whether to do that or not was right on. He had heart signs, and he had relief of those signs once the patient was treated. Has anybody else here ever used one of those kits or done?
I did it before they had kits. It was a 14 gauge, and we used to cut the finger off a glove.
Yes.
And poke it through there, so it was like a flap.
You can see it, yes.
So it was a kid with an auto action, he had the same thing, and I put it in, you could hear the hissing.
Yep.
And he, as you said he went, I feel so much better, and then they flew him off.
What was your
Yeah,
experience?
it was an accident, and the lady felt better.
I have to say, one of my most embarrassing cases is I've done a lot of tubes and needles and things for pneumothoraxes, but I put a right-sided IJ catheter in a woman I was prepping for surgery. It was an urgent, but not life-threatening, immediately life-threatening surgery, but she needed to be in the OR within an hour. And the vascular surgeons came down to the bedside. Fortunately, I had a good relationship with the main vascular surgeon who was interviewing this woman, asking her about her allergies, about reactions to anesthesia, trying to introduce himself, trying to tell her what he was going to do. And there's a whole team of residents behind him that were all in these long white coats, and I'm on the other side just trying to get her ready, getting the IVs ready, getting the fluids ready. And she turns from the vascular surgeon and looks me in the eye and says, "I don't feel so well." And I look up at the monitor and she starts to break it down, and her pulse ox goes from 100% to 98 to 90 to 88, and she says, "I can't breathe." And I knew that I punctured her lung when I put that line in. The line was working, but it probably nicked the top of the pleural lining and just, coasted along there, got into the vein. Everything looked okay. The post-chest x-ray was okay, but there was just enough time for that air to start seeping in. And I looked at her and I said, "I think I probably punctured your lung when I put that in. Can I fix it?" And she said, "Please save me. I think I'm going to die." And so while these guys were standing there actually with their clipboards writing all this stuff down, and they didn't stop. They were just like, "This is curious," because they were so focused on what they're doing. I actually just splash some betadine, cut through her skin, got down to the lung because she was really looking bad, and put my gloved finger through to puncture into the space to release the air. And the weirdest thing happened. I felt my glove break, and I pulled it out, and my whole, the whole top of the glove had just self-destructed. So I pull out my bare hand with the glove still on it, with her blood all over it. I'm looking at this and I'm thinking to myself, surgeons really hate it when you break sterile field. And I'm looking at her and she's gasping by now, and she's cyanotic, and the surgeons are all standing there with their mouths open because they're seeing my bloody hand. And I'm just shaking my head and I say, "Sorry guys, I gotta do this." And I stick my finger back in there, puncture through, I hear the come out, and she wakes up, goes, "Oh, thank you, that worked." And without missing a beat, I'm just like, I gotta wash my hands and put a new glove on. The surgeons on the other side continue the whole interview about the pre-op checklist, and I had a really good relationship with that vascular surgeon, and he thought it was a very interesting scenario, but he thought I handled it okay. Never mentioned the non-sterile field thing. Okay, let me just get down here. The second case this is a case that happened early in the year, in January. There was a medic intercept with Warren Rescue that involved a 16-year-old driver who was in a two-car accident. Does anybody here remember that or was on that scene? You want to just tell us? Second truck.
Not sure. Yeah, 16-year-old unlicensed driver.
Ah.
Bill was there. Could have been there. Lewis's farm equipment there.
Yeah, Route 90.
Oh, yeah.
Route 90, Route 1.
Oh, yeah, that's the one that we came upon it.
Yeah. That's right.
Right,
Back to the
exactly.
hospital and called it in.
You were returning from a previous intercept.
Yeah.
That's right, that's it. So you guys were primary there.
I had a medic and advanced in the back, and I was driving. I says, oh, there's an accident ahead. And there was.
That's crazy.
It was, the female had, double femur fractures. The male, we took him over. Of course, it was pouring down rain, life flight wasn't coming anywhere.
Right, I know Life Flight was called.
Events of what my life.
Yeah, it was the male that I took, there was really nothing wrong with him, he hurt his leg, but he wasn't, I think he's probably released that.
Oh, that's the
But
guy in
she
the
was-
other vehicle?
Yeah,
No,
Oh, the guy in the passenger seat?
I'm not, who took the people in the other vehicle?
Your other rig. Your rig.
That's right, and he had some, he went to Maine Med.
He had 2 broken ankles, but he was my patient. And he's probably had a concussion the way he was acting. And he got out and stood on his 2 feet with 2 broken ankles. I couldn't keep him in his seat. I tried, I couldn't keep him in his seat.
wow.
And then Terry took him in.
Yeah, Terry took over to Miles, I took our guy to
And back,
Penn Bay,
yeah, and the female went.
and the female went to Miles and right to Maine Med.
So one of the interesting things was Miles had both the drivers of both vehicles in opposite rooms.
Yeah.
And they had a little bit of a scene issue because the girls' parents came in and knew somehow that the driver of the other vehicle was in the other room. And Tracy Tippy, I think, was on duty that night. It was a night scene. And he said he really appreciated having both EMS stick around and later law enforcement just to try to help calm down the situations and do what he needed to do. So she ended up having 2 bilateral femur fractures, and she broke several bones in her right ankle, had a grade 3 splenic laceration. And then when she got to Maine Med, started having some neurologic deficits that were profound. So in follow-up, I found out that she was intubated and at some point lost responses. Let me just see if I've got the exact thing. So she had been extubated after she had her initial surgery for fixing her femurs, but in the recovery room, they found she couldn't protect her airway, so they reintubated her, sent her back to she went to the pediatric ICU, and the next day she didn't withdraw pain, she had no responsive spontaneous movements, she had reactive pupils and a light cough reflex, but pretty sad neurologic issues that subsequently were found to be due to fat embolization. And fat embolization, like other types of embolization, occurs in trauma, especially with breaks of large bones like the femurs, where the fat in the bone marrow comes out of the normal cavities that it's kept in and goes through blood vessels that are lacerated, circulates through the heart, and in her case went to her brain. So she basically had strokes from little fat globules that came from her legs, from the trauma in her legs. And that was actually her primary problem because they were able to control the bleeding of her spleen, fix both legs and her ankle, but she had a prolonged ICU admission at Maine Med because of the brain damage that she had just from this rare associated traumatic thing that we sometimes see with fat embolization. There's really not anything that we can do in the field to prevent that. She got sick, had a hospital-acquired infection, also got antibiotics for that, but in about a week in the ICU, she started to recover her neurologic function. And they basically treated her like a stroke patient. So she got physical therapy, occupational therapy, and a lot of other types of support. But I think probably in her case, she didn't have permanent anoxia from the embolization in her brain. It was partial enough that she was able to regain nearly full function, enough so she could walk, sit, and speak mostly full sentences in 2 weeks. And the last follow-up that I heard after she was discharged is she went to rehab at Spalding, which I think is in long-term stroke management type of rehab. And I haven't heard anything about how she's done since, except that she was discharged home and has some pain and mobility issues, but appears to be neurologically completely intact. So that was an interesting case, and I think it would have been a much worse outcome if you guys hadn't just happened to drive by. If that had been another 20 minutes, a lot of other bad things could have happened. Okay, I've got 2 other cases. Oh, one of the things that I do want to mention is that she got TXA en route to Miles, which is absolutely the right call. It's something that I think I've mentioned before. It's something that we don't often think about in the ER setting because we've got so many other things that we're thinking of. But if you guys do it in the field, it kind of prompts us to remember, oh yeah, that's potentially life-saving. And after the bolus, which is a gram that you guys get in the field, we can hang the drip and start it so that we know that we're still doing the same thing. So that was a great call. Okay, I'm trying to find, there's a case here, Orel, that you were involved in. Here it is. Tucker Reed Road is a 70-year-old male, and this happened in July, who you went to pick up for chest pain. Sudden onset, woke him up from sleep at about 11:30, and do you remember that case?
I think so. I don't know.
No, that's okay. Let me just give you a bit more.
I think I had a driver, if I remember correctly, and we went for chest pain. And what do you think? Sitting there.
Yeah, it's not
Well,
really.
You took the main med right afterwards.
Yeah.
Okay. All right. Yeah.
The one
And
that
he
put pads on in the
was
ER.
just sitting there. I don't think he had any history of heart attack or anything, and he said something about it. He had a family history. And jeez. Okay.
Yeah, I remember it now.
So I just put a 4-lead on while my driver was grabbing the stretcher, and I immediately saw elevation.
I'm trying to put up the EKG so you can.
Yeah, I did a 12-lead. I yelled, "Hurry up!" And yeah, he had some significant elevation. I think that's the most elevation I've seen with a patient. Reciprocal changes in what? V1, V2.
That's right.
V3,
That's pretty good memory.
4. And it was an inferior.
It was. He had ST elevation,
Yeah.
2, 3, and F.
Yeah. So during
There we
transport, I was very busy. I think he had bilateral 18s. I can't really recall, but I think I tried to do that.
You did. You
Gave
did.
him aspirin, I believe.
You did.
I may have tried nitro.
You got nitro.
Okay.
Yeah.
It didn't relieve the chest pain. I think the first round did, and the second round didn't. And he wasn't in. I mean, he didn't look like he was in distress. He just knew that something wasn't right. And,
So the reason I put this in is because this.
So during transport, I kept noticing while I'm frantically trying to give him fluid, and I just tried to do a bunch of stuff all at once. I didn't stay on scene at all. I noticed that he was going into an arrhythmia. It looked like AFib.
Yeah.
And then he'd go into a sinus rhythm, and it looked like AFib, but then I wasn't sure. I wasn't sitting there and staring at it. It could have been a second degree, now that I think back. But I think I looked at it at one point, and it was AFib. And just prior to pulling into Miles, like as literally we were pulling into the driveway, he said, Arel, I don't feel so good. And he just laid his head back and that happened. And I had laid the pads on him, but I didn't stick them on him while we're en route. I'll never do that again. I'll always stick them on. I'll always stick them on now. So.
Fortunately, that was short-lived. But
Yes.
That could have been a terminal event. It looks, the second and third leads look like VTAC, but the first one shows an organized rhythm. So I think it probably was a rapid AFib that was aberrantly conducted, or you're seeing the ST segment changes so that it's just kind of masquerading as some kind of like, it's a wide complex,
Yeah.
but who knows why.
Yeah.
And I got some very good follow-up on him. So he got Lytix, aspirin, Plavix, and a heparin drip in the ER. Didn't really change his scenario at all. He still felt terrible. He still had massive ST elevations and an AFib that was new for him. So he went straight to the cath lab, and his right coronary artery was pretty much completely thrombosed. So
we actually stayed for that. We brought him to
good.
Maine Med.
Excellent.
So,
So he had what was described as a large, complex thrombus. He got stented, and the stent took a while. I think they said they had difficulty passing it and working through this big, huge blood clot, which was inside of a really gritty, plaque-lined right coronary artery. But they eventually were able to restore flow. And he went to the CICU with chest pain remaining. And that concerned the cardiologist a lot. They did a lot of other things to try to figure out why. And they concluded eventually that they probably knocked the blood clot into little tiny pieces that just went all the way through the coronary circulation. And they lodged in the tiny coronary vessels that were distal and caused a lot of microinfarcts. But the main burden of the clot was relieved. He turned out to do well. He had recovered his EF. His ejection fraction was normal a few days later. He had some residual echo evidence that he had a pretty big time MI. But he was discharged in good condition. And the teaching point here, I think, is that we talked about this a few times in the past, but the inferior wall of the heart. So imagine the heart is like my fist here in the left side of my chest, and for some reason, anatomists named the top part of the heart here the inferior wall, which comes from some historical thing. Usually we think of inferior as in this section, but the base of the heart is the inferior wall, and it's mostly it's the one you wrote the letter for.
I've heard before.
Yeah.
I just took the last
You've had a lot of silly calls lately too, I've noticed, and then some serious ones. So this side of the heart primarily is the right atrial wall. And the right atrium has in it a dime size, actually it's more like the size of my little fingernail, the SA node, which is the pacemaker part of the heart. And it's a weird place to put it. And it's also weird that it's just that little tiny piece of tissue in the right atrium that guides all the rest of the heart. So if you knock out the right coronary artery, most people, more than half of people, supply the right atrial wall with the right coronary artery circulation. You have a lot of trouble with arrhythmias. And it's more common to see arrhythmias primarily from that mismatch in blood supply with an inferior wall MI, which is what this guy had, than any other type of MI. The other thing that you should know is the right coronary artery in 90% of people supplies the whole AV node, which is the secondary conduction part of the heart. So if you knock out your SA node and you don't have a pacemaker left in your heart, the AV node, which is the big piece of tissue that separates the atria from the ventricles, it's a big piece of muscle. it's got this primitive pacemaker in it that we see when we see escape beats or escape junctional rhythms. So it tries to take over, but it can only really do 30 or 40 beats a minute poorly. But 90% of the AV node is also supplied by the right coronary artery. So having weird arrhythmias with inferior wall MIs is common, and it's a good reason to have pads on. But the treatment for it, really, it's a mechanical problem again. You got to get the clot out. We used to give all of these people lidocaine. And lidocaine still, amiodarone would work. Many dysrhythmic medications you could give by IV, and it would fix the arrhythmias, but the heart's still starving for oxygen. And we actually found in a lot of these big studies, and I was a firm believer that you should give everybody lidocaine when they're having an IMI, but the outcomes actually turned out to be worse. People who had nice looking rhythms when they had stuff that you saw because you gave a shot of lidocaine did worse because I think maybe we felt like we were treating something and it looked better on the screen, but the heart's still starving for oxygen and there might have been more of a delay to get the right care. We're not really quite sure, but that whole thing went out of ACLS a long time ago. Okay, last one is a woman who presented, let me just see if I got it. There's also an EKG in this one too. This is a 69-year-old woman, and this was from November of last year, who had shortness of breath, and she just finished chemotherapy. She was being treated for cancer that I can't quite remember. She had a pacemaker, she had an AICD in place. She was chronically on oxygen, and the reason we included this is because once she got on the monitor, she had a wide complex tachycardia. Okay. You guys saw it for a second, right? There it is. Okay. So she had this complex, and she had the EKG interpretation is probable VTAC, and she clinically was in that condition. She had some objective signs that made, I think this is Derek's case again, consider doing something like cardioversion. So, any comments on what you guys see on this EKG? It's fast. It's wide complex. There's a left bundle branch block there. Just because it's fast and wide, the first thing that we should always think of is VTAC. In this case, it's a little bit more complex than that. VTAC generally is a really nice, smooth pattern. And there's some jagged points here that make me think, when I first saw this, my first reaction was, this isn't VTAC, but if the patient is hypotensive or hypoxic or confused, this patient still should be cardioverted before you just sit around and try to figure out what it is. And I think that's exactly what Derek was thinking, and he did a synchronized cardioversion on her in the field at 360 joules, and she converted to a normal rhythm. So I've got it. There we go. There's the
call in a few minutes.
Yeah.
Incoming call.
So the rhythm that she cardioverted to, actually on here it's interesting, you can actually see the synchronization beats on the left. At the very bottom of each of those QRS complexes, there's kind of like a little triangle. That's the defibrillator locking on the patient's own heart rhythm. And it's important to remember, if you have somebody that's not in VFib and they have an organized rhythm, to always press the synchronized button, because the chance of success in cardioversion is so much higher if You deliver the shock at the exact right moment that has to do with when this person's heart is going to beat again. So you shock it at the most prime time to get things to reset. And that's what it did. So you can see the shock, and then you see these long spikes. This is the patient's own pacemaker returning to pick up the heartbeat and recapturing the heart. So the two teaching points here, in the ER, even with all of the rest of the expertise and the EKG machines that we had, the physicians weren't sure what this was. They thought it still could be VTAC, like you guys saw in the field, or it could be something else. And it really wasn't until the patient went to main med and had in the EP lab, Dr. Carpenter, Charles Carpenter, only in the EP lab was able to say this wasn't VTAC, it was an aberrantly conducted wide complex, probably AFib or A-flutter. So it just kind of goes to show how complicated it can be sometimes to determine really what this is. But the key lesson is if the patient's unstable and they've got a wide complex tachycardia, the treatment of choice is cardioversion, synchronized cardioversion. The other point that I would make is synchronized cardioversion, if you have time, you don't have to start at 360. 360 is what I've got a lot of old-time cardiology friends that say, I'm just going to do everything starting at 360. But for the patient's comfort, and this person wasn't sedated, she got a little bit of something, but she was unstable enough, he just pushed the button, and 360 joules is something you don't ever forget. You can usually cardiovert somebody in any kind of complex, unless they're really, really, really big, even with 50 joules. In fact, you can sometimes do it with 20. So you can always try, if you've got 20 extra seconds, start at 50, hit the cardioversion, or hit the synchronize button, cardiovert. If the patient doesn't immediately cardiovert, then you can go up to 360, or you can go 120 and then 360, whatever it is.
I think they're teaching, because I had that same discussion with the newer medics over the years.
Yeah.
And I don't think they're teaching them stuff. I always started at 100.
Yeah, exactly. I think that might be the reason.
They're not telling them that anymore. They say, no, just hit them.
that way too.
It may be that the protocol has changed to simplify things, like we've kind of simplified a lot of things in ACLS. But between you and me, if you ever choose to do it with a more finesse thing, it's going to be nicer for your patient. And if you've got the time, generally 20 seconds in a perfusing wide complex tachycardia where the patient just isn't unconscious and comatose, you've got a little bit of time to maneuver.
I cardioverted one. His rate was one of Bill's patients in Jefferson. His rate was 280.
Yeah.
And I cardioverted at 50.
Yeah.
So,
and it's really, it's a good feeling when you do it.
Yeah, because I'm like, I minimally affected this patient, but I cardioverted him too. So it's like.
And you think about it, I think I grew up in an era where we used to do the precordial thump, and I'd still do it if I was presented. And I've had 3 patients who, 2 of whom had VFib, who I cardioverted or defibrillated with the precordial thump. I mean, I banged them hard, but that's about 50 joules if you hit them hard enough. And it depends on how quickly you can get. If you can get electricity to somebody in that period of time, you can usually cardiovert them with much less. It's easy to just punch somebody in the chest, you just see them and you punch them, that's a second or 2. So you have a window of opportunity that gets harder and harder as time goes on for cardioversion or defibrillation. So that's all I got. I'm really happy we could do this. It's been a weird few months. I'm hoping things are gonna get better. I'm really happy that we live in Maine, where the case rates are much, much lower.
Wave to the people on YouTube.
Yeah. Oh, thanks guys, thanks for coming. And if you have any interesting cases or any topics that you want to go over, let me know. The organ donation topic actually came about because about this time last year, one of the medics in the audience said, can we talk about organ donation? I thought it was a great idea because it's been a year since I actually had somebody talk about it, and a lot's changed.
Thank you very much.
Yeah, you're welcome.
Make sure everybody signs the roster.
I did.
Okay, good, okay.
Yeah, and
Just start with this, I guess your signature at the bottom.
Yeah.
Is this the one, or did he already take it?
Yeah, we need some evaluations filled out, I got, send those in. Okay. The other stuff there?
That's who I have on it.
How are you, Dr. Lee?
That's good.
Bill Nicholson.
Hi, Bill. Yeah.
Everybody gave.
I normally take your hand.
In my previous life as a medic in Northern Virginia, a cardioverter, a Russian tourist. And he kept screaming at me in Russian. And my partner was the son of Russian immigrants.
Oh, yeah.
So I said, okay,
Yeah.
I guess scan your check.
Yeah.
but he said, I don't mean it personally.
It's just because it really hurts when you do it.
Yeah.
It's still the right thing to do, but if you
Yeah.
have a way to